are my disclosures. I work with multiple pharma companies and genomic companies, and I'm a co-founder of ILON Precision Oncology and Impact India International. So to talk about 2023 year in review, I kept New England Journal of Medicine as the focus because that's our gospel, that's our epic. And, it just, if we cover what we saw during the year, even briefly, I think we would have covered a lot of the stuff. So we had to have many panelists, and I'm wondering who all have joined. Of course, the senior most, the godfather of oncology, Dr. Professor Suresh Advani, sir. He's supposed to be joining us. I'm wondering if he's is here.
We have connected to most of them. They're on their way to join. As
Okay.
of now, Dr. Preetham and Dr. Marzi has joined. So
Okay.
we'll get back to you once. Once you
Okay.
present your pray, we are trying to get them on board.
Pasade, Dr. Vashisht Manyar, of course, Dr. Vijay Haribhakti sir, our chairman of oncology, Preetham, and Dr. Preetham Kataria, our youngest star, and Dr. Marzi Mehta, the star from thoracic surgery, oncology. And so we lack a radiation representation today, and I'm really, really feeling that. But in any case, so I think the way I'll go is I will give a quick overview of what I would like to discuss, and then as and when people join, we can pick on them. It would be unfair to ask away all questions in medical oncology and discuss them with Preetham. But Preetham, you're most welcome to chip in and contribute. So I found some very intriguing work that has been discussed through the year. So in breast cancer, a very provocative article published very recently was omitting radiotherapy after breast conservation surgery in luminal A breast cancer. And actually, these are women, and I purposely kept the method and the conclusion here. These are so ours is a slightly different style from the style that was seen with the hepatology team, and we kept the year in review really very much front and center. So that's why these are articles that have been presented, and these are seminal practice-changing original work that has been done and presented and published in one of the leading journals in the world. And the reason to bring these up is some of these we will imbibe and bring it in our practices, and some of these we won't. So one such work was this omission of radiotherapy in very, very early stage. So T1, grade 1 or 2, luminal A breast cancer, who were at least 55 years of age and had had breast conserving surgery and endocrine therapy alone. In this particular population, the local recurrence at 5 years was very low with omission of radiotherapy. This is a single most effort with the Lumina study investigators, and the tumor size that was kept here was less than 2 centimeters. And the Ki-67 index was 13, the median was less than 13.25%. So just to give a context, we normally, for any breast conserving surgery, we follow that with appropriate systemic treatment that the patient qualifies for, and then we do radiation. Then we put them on hormonal therapy. However, in this study, they have, for very early stage, low grade luminal A breast cancer, hormone positive breast cancer, in women who are above 55 years of age, so postmenopausal, they've omitted radiation in one of the seminal efforts in radiation oncology. The other very remarkable study was interruption of endocrine therapy for women who were hormone positive and young and wished to have a family interruption of endocrine therapy to then complete their families after they had been exposed to almost 2 years of endocrine treatment. And then they went off the endocrine treatment for a while when they had their pregnancies and resumed the breast cancer treatment again. And in this, there was actually a follow-up. If you read the lower blue square, it says there was a follow-up of over 3 years post their resumption, and there was no difference in the survival rates for these women or the recurrence rates for these women. So I will halt here, and I'll speak to the lone soldier. I think Preetham is here, and because these are also surgical, post-surgical questions, Dr. Marzi may chip in as well. But Preetham, any thoughts on the endocrine treatment, and do you feel we could take this into our practice? Is this practice changing for you?
Uh, so, ma'am, yeah, ma'am. So, a nice presentation again. I think, this is a very important question that we all face in our OPD, and especially we are seeing a lot of young women getting breast cancer, and it becomes very pertinent that, especially in those patients who are hormone positive, what to do, especially when they are around between 30 35, or between 30 to 40, and they get with the breast cancer and they want to complete their family. What we know is that the endocrine therapy can have a phytopathic effect, and so and what we understand is the washout period should be around 6 months, but almost a year after you stop the endocrine therapy. And uh, so and whether after giving chemotherapy these patients will be able to resume their menses. So there are a lot of questions that comes to the mind of the physician and as well as the patient. And so I think important study, and I think this gives us a boost to understand that yeah, there is some data to consider this way in those patients who really want to look for pregnancy. Now, the only problem is that this in these patients, who what we know is that in hormone positive breast cancer, these patients would have late recurrences and may not have early recurrences. So we would like to look at the longer follow-up before we really say yes, this would be the right approach. And obviously, these patient, I mean, in early breast cancer, where the risk could be low, we would be more inclined to have this approach. Obviously, looking at the other risk factors in the histopathological report to really give this approach to the patient. But yes, this is something which can be tried. But yeah, for a longer population, or to call it a standard of care, we want to have a longer follow-up.
So I understand you will do it with caution. You will only do it for, one-off patient where the patient is desperate. It requires more data. It requires more nuances. It requires nuances regarding the biology of the disease. And I felt the same, that we have very short-term follow-up yet in these patients where you need adjuvant information and survival information for decades. And that's how the breast cancer rules have been formed. So the rules of not allowing pregnancy are several decades long. And one cannot challenge that just with a 3.4-year follow-up. So very well said. I think we need to wait and see how the study pans out. But in that one desperate patient, I think uh, we are comfortable now that we have some data interrupting the pregnancy. And in the first study, I don't think, none of us are ready for this kind of exemption, right? I think the radongs would have a heart attack if we were to say, Mazi, are you wanting to say something?
Yeah, so see, actually, on a real practical note, so we see this time and again that women, at least of the Indian population, they veer off from a conservation therapy only because there is a long drawn radiotherapy on a practical note, right? And those cancers which are actually, I mean, the last one which we did about a couple of weeks ago, by a very prominent surgeon, was offered a mastectomy. She was 70, but she was very, very keen to preserve the breast. Of course, the whole conversation revolved around the fact that where will she take radiotherapy? So she again changed her mind to saying, okay, fine, I don't have radiotherapy access, so let me do mastectomy. And then the sons intervene that we'll do something. So it is actually a very important aspect, like that. If there is a select subset, of course, this lady had a tumor which was almost like 3.5 centimeters, so there was no question of she falling into this particular category. But if we can identify women, in which we can say that yes, with breast conservation surgery, we can still, I mean, there was a Silverman's trial many, many years ago, which did actually look at the benefit of radiotherapy in breast cancer with all these 0.5, 1 centimeter, 2 centimeters. I don't know, somehow that a study did not receive much of an accolade. And in the years to come, that actually just, I don't know, maybe you are the better person to tell me what happened to that
No,
study.
actually, so I think with the breast conservation approach, there hasn't been a whole lot of a momentum once the studies resulted in higher rates of local conservation, decreased relapse, and increased survival. Once we had proven that, to challenge the paradigm, one would again need head-to-head comparison and long-term data. Just by omission, one cannot accept what has been the baseline standard of care. So that has been the biggest challenge. There's no head to head. And if you don't do head to head, and who's going to participate in head to head? So, so that's been the biggest challenge. And I think we need to really do preventative studies a little more aggressively. But until then, I think none of us will omit the
Yeah,
standard.
absolutely, absolutely.
Continue to. So now, coming into the lung cancer arena, I think the biggest studies this year are from lung. And we saw osimertinib. So we have two types of adenocarcinoma lung and non-small cell lung, and it's mainly driver mutation positive and driver mutation negative, those that are attending. And in the driver mutation positive lung cancer, we had multiple seminal studies presented this year. One of the major studies was osimertinib for EGFR positive lung cancer with or without chemotherapy. And in this study, we saw the survival advantage. Whether we are ready for prime time utilization or not, we'll discuss that in a second. And then we have ROS1 positive and a new drug with reprotectinib in ROS1 fusion positive lung cancer. Again, non-small cell adenocarcinomas that are ROS1 positive benefit from reprotectinib. Up until now, we have crizotinib approved. The next drug, this is reprotectinib. The advantage is that it crosses blood-brain barrier, has better results. Are we ready for utilization? And then we have a whole host of trials between durvalumab here with the AGAN study. I was one of the AGAN investigators. My name is somewhere on the paper as an acknowledgement. But we have a whole host of immunotherapy studies with durvalumab, nivolumab, pembrolizumab, atezolizumab, all in early stage lung cancer, where these lung cancers are resectable. You give neoadjuvant therapy with chemoimmunotherapy and adjuvant immunotherapy, and it has been shown to enhance response, shown to enhance disease control and decrease relapse, and in studies has shown to enhance survival. So that's another lung. And then we have the new kid on the block, a drug called amivantamab. Amivantamab is now being proposed for a very specific type of driver mutation positive lung cancer called exon 20 insertion. So again, a very, very specified, these are seminal papers. These are out there front and center. in the New England Journal of Medicine. And so I guess the world has to know all these biomarkers now. There's no running away. So exon 20 insertion and amivantamab is a drug that works on this specific, it's a mAb, so it's a monoclonal antibody that works on the extracellular domain of the EGFR receptor, and all the MIBs work on the intracellular domain of the EGFR receptor. So this works on the extracellular domain. It's a very rare kind of mutation that it targets, and it was just presented in New England Journal of Medicine. And of course, you can see the survival curves are separating very well. Amivantamab plus chemotherapy. The trial is called Papillon trial. And amivantamab was also presented with chemotherapy in osimertinib resistance patients. So now that we are doing osimertinib for EGFR positive lung cancer, and those guys who develop resistance to therapy in, let's say, 2 years, 3 years, they can go on to amivantamab plus chemotherapy. And then you have another mutation called RET fusion in lung cancer. And so first line selpercatinib for RET fusion. So you heard the ROS and you saw the RET. And then moving on to other malignancies. Before we go there, lung cancer. So one message, Marzi, from you, and one message from Preetam, or any messages regarding lung cancer. What are your thoughts from seeing all these papers that are coming in? Preetam, you want to say, go first?
So I think, ma'am, with respect to the lung arena, I think, we are sort of going in an arena where I think we'll have long survivors for patients with lung cancer, and possibly in a decade to come, I think we could have cure for stage 4 lung cancer also, looking the way the data is coming up for these patients. So osimertinib had a survival benefit as a alone agent, and I think we all wanted more, and I think this is the next trial where they've combined it with chemotherapy. Especially with we assume that the benefit would be more in those patients where the burden of disease is very high. And I think, the survival benefit is not yet been sort of shown because we want a longer data, but I think this is where we are moving into. We are combining the TKI with chemotherapy. The previous trial of osimertinib, when the cost of the osimertinib was very high, and it was compared with geftinib with chemotherapy. So I think they're taking a cue from that. I think this is the next trial which they have combined osimertinib with chemo. And those patients who have progressed on osimertinib, they are giving amivantamab with chemotherapy again. So I think, so I think for many years we were stuck. Those patients who progress on osimertinib, what to do with this patient? And those patients with exon 20 insertion, what to offer? Because what we knew was the chemotherapy alone may not have a great impact, and a TKI alone may not have a great impact, the osimertinib that we had. So I think amivantamab plus chemotherapy, improving the PFS to a greater extent, I think this is something, in a poor subset of patients with EGFR 20 insertion, I think we have a good combination which would improve greater avenues in terms of improving the progression-free survival.
Very well said. I think the current horizon has opened up with all these presentations, and I say if I sleep for a week, there'll be a new drug approved in oncology. So it's actually, it's wonderful times, but it's also very intimidating for me and Preetam, especially because we truly need to be up to speed. We need to know what was the trial presented, what kind of benefit you had, and cannot take these trials on face value. We have to deep dive, we have to attend lectures, we have to come up to speed with whatever is being said, so that you just don't take by the conclusion, and we know the nuances of utilization of the combinations. So so that was non-small cell lung cancer. But before I go, I think I just want to ask this question to Marzi. What do you think about the immunotherapy in the perioperative setting? Have you changed the way you used to approach patients? Earlier, we just
You don't absolutely. I think so. See, I have been, I mean, I know just revealing my age now, but I've been into the thoracic surgery before, rather in the pre targeted therapy area, which was the 2009 Tony Mock's presentation, where we 2008 was like, okay, you just can't do anything, just go back home. To what we are now seeing in these last 10 years has been an explosion. In fact, we are looking at so many cases. I mean, together, if you recollect that, the ones which started off as kind of like labeled as stage 4 and always a stage 4 is what I was taught, and now it's changed the whole face and the way we deal with these cancers. It's been a lot different. As you rightly said, each new drug which comes in has to be deep dived into. We cannot just take every drug at a face value. But I think what we have been noticing over the years is at least every 2 years, we are definitely having some great breakthroughs and really robust ones, which have really changed the practice. And yes, what started off as a very rigid thing like surgery is the only cure, you've made many surgeons believe that no, that is not the way forward. It has to be a multidisciplinary approach. And yes, I'm totally with it that we are, I mean, of course, one of our greatest, of course, I'm deviating from the topic, but the cross protocol itself stands testimony that what was only surgery with a 25% success rate has now actually gone to almost like 45 to 54%, which is a huge leap. And that time and again does tell us that these advances cannot be swept under the carpet. Surgery is one of the stays for cancer treatment. But yes, there are lots of other things which are also supporting in the longer run, for the
longer.
long
Yes.
survival of the patient. Yeah.
So to achieve a longer duration
Longer
of,
duration of DFS or a PFS, whatever is our goal, right? Sure.
right, great. So I think there is more hope for lung cancer patients, one, and two, what I heard from Preetham and what I heard from Dr. Marzi is there is paradigm shift. There is paradigm shift in targeted therapy and realization of application of targeted therapy. And of course, there is paradigm shift in how we approach our patients even when they are early stage. Uh, Changing gears to another malignancy, that's thyroid cancer. And the reason to put up this slide, of course, it was there in New England Journal, so of course I would need to. But the reason to put this up is because we saw RET in lung and we are seeing RET in thyroid, and it's the same issue of New England Journal. So what the message that I'm trying to give through these different slides is precision is everywhere. And you have to find the red fusion, you can treat the lung, and you find the red fusion, and you treat the. And then coming to some of the stuff in other malignancies and in bladder, we saw nivolumab plus gemcis enhancing survival. And you saw erdafitinib versus chemotherapy in TAC3 fusion positive bladder cancer, and you saw benefit in those patients. And then you saw KRAS G12C positive colorectal cancer. And these are, I'm not skipping any publications. I'm not skipping any original articles. These are issue after issue, and the message is intact. You're looking for biomarkers. So here is KRAS G12C, and sotorasib is an inhibitor. Like I said, IB is a TKI, so it's a tyrosine kinase inhibitor. It's a pill, and it's being given with panitumumab, which is a EGFR inhibitor, and it's a MAB, so it's a monoclonal antibody attacking the outside extracellular domain. And here we are using it in a particular type of colorectal cancer. I forgot to put up the slide for KRAS G12C pancreas cancer being approached with sotorasib for advanced pancreas that is KRAS G12C mutated. That was also a New England Journal publication. And so GI, GU, you saw multiple GU here, and here one thyroid. And then coming to the G by N, where we saw another ovarian cancer trial with mirvetuximab in particular folate receptor positive ovarian cancer, and then in endometrial cancer, seeing dostarlimab and pembrolizumab. So before I move over to the last few comments, main thoughts from Preetham, just to not trouble you too much into each one of these malignancies. But have we up all these? Do we practice, for example, if you got a bladder cancer patient today, would you be looking at immunotherapy plus chemotherapy?
So yes, ma'am, I think the it just gives us a more impetus to use immunotherapy in the frontline setting in advanced urothelial carcinoma, and because especially where the platinum in ineligible patients, we have been using it, but this gives a license to use in those patients who are platinum eligible also. So I think we will have more deeper responses and long-term responses with after giving the chemotherapy. So this is one trial that is sort of giving us that sort of way
Data.
to practice. Yeah.
Exactly.
So
And are you looking at pathways in bladder to
yeah, so I think those patients where we have a the precision pathway, and we have a pathway where we can target it. So adapatinib is something, and also it is coming in combination with immunotherapy also versus chemotherapy trials. So the things are changing over the time. I think we'll have more. So in bladder we only had either platinum gemcitabine or a taxane, but now we have many more agents, and it's going in the way of lung, where this malignancy which was seemed to be very difficult to treat, now we are getting more and more agents in this space, and I think that is something increasing our treatment avenues. Yeah.
so many options come up in bladder also. It's
Yeah.
just
Colon, again, we were stuck up with Folfox or Folfiri. I think those patients with KRAS G12C, we were not confident of adding only sotorasib or adagrasib, but I think combining sotorasib with panitumumab is something we wanted to, and actually may improve. We have panitumumab with us. Sotorasib is something we don't have still with us, but I think once it is launched in India, I think we will be more be able to, and also through the clinical trials, which we are all trying for, under your guidance to get it to our hospital. I think will help us to provide the benefit to the patients where we don't have any other agents to be given. I think so. This is something which is increasing our thought process in this field actually. So this is again precision, because there was nothing beyond that.
we are all now we've become aware we have some options, and where earlier we didn't. Now, folate receptor antagonist, we still don't have folate receptor testing, and I'm really breaking my head because patients ask for this drug
Yeah.
now. This is an FDA approved.
So I think after trabectedin, there was no drug in this segment for ovarian cancer, and I think the trabectedin was obviously olaparib is for BRCA positive, but after trabectedin, there was no chemotherapy drug that was established for ovarian cancer. I think this is something is a big breakthrough in ovarian cancer, as we all know that immunotherapy has not found that great space, and I think this drug, let's see how it could be a game changer for us. But we have one more ammunition to target ovarian cancer. So looking forward for the same. Endometrial cancer, ma'am, again the same story. We only had limited chemotherapeutic agents, either taxane plus platinum or liposomal doxorubicin. I think this is uh, something which sort of we were using pembrolizumab plus lenvatinib in those patients who were non-MSI high or MSI stable actually. So this is again combining with chemotherapy, and endometrial cancer, which was difficult to treat 5 to 6 years back. Again, we have something to come up in this segment. So I think immunotherapy is getting a space in almost all the cancers, and the different pathways have been sort of looked at to provide the agents. It's not just now breast or limited malignancies. I think we are getting in all the segments, and that is a very, very welcome move to sort of look at all the malignancies, just not looking at the few malignancies which are very common. Yeah.
Thank you. Thank you so much. Thank you for holding the fort, Preetam.
Thank you, ma'am. Thank you, ma'am, for this question.
I think I'll just wrap up with the last few seconds. Very well said by both Dr. Preetam, Dr. Marzi Mehta. I'll just wrap up by presenting this. A lot of these studies, and if you look at 90% of these studies, and some of them that I couldn't put on, most are biomarker driven. So when we say precision, it's just a cliche. It doesn't belong to me or anyone in particular. It's all of us that are practicing any kind of medicine, but most certainly oncology, because we have had very, very generic approach over the years, and the world is changing. It is new age time. When you have new age biomarker access and you have to produce biomarker directed evidence to advancing therapy in oncology, and um, this is yet another way of instigating and presenting the data on and discussion on precision and biomarker directed treatment. Of course, as we move from treatment towards prevention, a lot of new information coming through in terms of risk reduction and reduction of directly linked in this very nicely done special report. And some of these special features, one that really caught my eye was this in utero development of enteritis, pembrolizumab exposure that presented in a 4-month-old baby that was treated with prednisolone and infliximab. And these messages stay with us, finishing the discussions with our own precision center that we have established, where we do all of this together. We are bringing multiple clinical trials where all of us will try to contribute. We are also trying to put together rare tumor group, and a neuro-oncology initiative has been put together by Dr. Shweta Bansal. We also have disease specific, so we have GI, we have lung, we have head and neck, we have breast. So all of this and more in terms of testing and molecular tumor board discussion and MDT discussion. One last mention into a cancer navigation program that we are trying to bring together. We have now put it all together as a concept, and we are trying to finish and channelize that. Finally, a final word and an appeal. All of you all, please bring your cases. Dr. Haribhakti sir runs a wonderful, wonderful multidisciplinary tumor board, and all of us contribute to that tumor board. Sometimes the tumor board just stretches through the morning and explodes through the day. But you all are most welcome to bring in your cases. We are really trying to run it in a multidisciplinary and presence from the ICU team, from the pulmonary team, from the nephrology team, GI team, hepatology. Everybody is most welcome. We see interdisciplinary participation all the time, and you're most welcome to come in there and ask questions, contribute, help us manage our cases. And finally, many, many congratulations to Dr. Arindam Kar for holding the torch and his latest degree. Congratulations and thank you for the opportunity for all of us and keeping the light on. Thank you, Arindam.
Just an sort of initiative where we can learn from all of you, because I always say that critical care is a little bit of more skilled general practice, right? We are more of a skillful GPB. We need to know every aspect. So we had so many of specialties coming, and the expectations are so high from every specialist or super specialist who are keeping their faith on us, right? So we need to know what you are expecting from us, and because we are there 24/7 sort of way, and we need to have a clear collaborative effect with you. We need to treat the patients under your guidance. So I think this will go on. Thank you for conducting it so well, bringing all the informations to
Yeah,
and we
for holding the fort.
Thank you, madam. And we would be publishing it. Not only the recordings would be available, but we would have we would publish it. And I really like the idea of Sarthi, the rare tumor boards. You see, I am a very quick learner, and I constantly try to imbibe good things from people, right? And I picked up that idea, the rare tumor clinics, then the Sarthi concept, where you navigate through all the entire course of it. So, madam, we would definitely just a beginning. We will all work together. We will collaborate together, and thank you, Marji boss, and also Pitam Bhai to come up on it. And we have already started the concept of critical care oncology, and at least once a month we would be continuing the classes itself, online classes. Thank you, Savanti madam, Pritam Bhai, and Marji.
The best.
Thank you.
Thank you.
Thank
Good night.
you. Thank you. Thank you, madam. Thank you.